Evet, tekrar hoş geldiniz. Bugün yine bir endoskopik yüz germe yöntemiyle ilgili sunumu sizlerle paylaşacağım. Şu anda tabii gördüğünüz gibi endoskopik yüz germe, mid-face lift ve alın germe işlemleri tartışılacak. Şimdi
Thank you for inviting, actually I say both Ryan and I again. We always enjoy coming and seeing everybody hearing about some of the different techniques. So Dr. Bedrosian just spoke about the brow lift and how he approaches it from the, is this me now? Okay. From the upper lid. I'm going to talk a little bit about endoscopic forehead lifting, and then we'll touch on mid-face rejuvenation, the surgical aspect of it. So you hear a lot about endoscopic brow lift, and a lot of people, certainly at our meetings, the discussion is, does it really work, and is it really permanent? Are they long-lasting results? And what I can tell you that we've been doing it for over 7 years now. We have a high patient satisfaction for it. There is, as Ed mentioned, there is a learning curve. Certainly, the technique that I use has changed over the last several years. You start to figure out what's working, what's not, and where you're falling short as the time progresses, and you make little adjustments. And certainly, the procedure is technique dependent. Again, the little changes in the technique that we've made over the years have made a big difference. Also, as I mentioned, the downside is you do need endoscopic equipment, although not as much as you think. So brows come in all different shapes and sizes. There is no one specific brow type or brow shape, right? Every patient has a different look. One of the things that you have to do, actually, we've talked about a little bit, was photos in the beginning. Ryan and I are both sticklers for photos. Every patient that comes in gets a full set of photos. And not only is it for their benefit, so we can talk to them about what's going on, it's really also for our benefit as far as protection, right? A lot of times patients come in, whether it's brow lifts or blepharoplasties or facelifts, and they say, well, look at this asymmetry. I don't understand it. It wasn't there before. And you say, well, let's look. And you go back to their preoperative photos, and lo and behold, it was there. And they go, I never noticed that before. And it's because all of a sudden, after surgery, they're looking at everything very meticulously. So this is just showing you a couple different, I just went online and picked up, but you can see the shape, the structure of the brow, where it's placed is very different. One better than the other? Not really, just different. And so when you're going to correct brow ptosis or even upper blepharoplasty, blepharochalasis, you have to really understand what the patient looked like before and what their expectations are. Certainly men, same thing. The classic male brow is supposed to be flat, but certainly you see plenty of arching and higher brows in men too. So the female eyebrow, the classic, interesting, I'll tell you an interesting thing. I went to look for a famous person who had brow ptosis. When you look for it, you can't find it. So anybody who has it doesn't want their picture associated. Nice brows, a ton of them. So a young brow is, although the shapes and the placements are very varied, the overall appearance of a young brow is pretty standard, and that is the brow is above the orbital rim, and that there's usually an arch to it, okay? And then the arch placement is variable. Some have it a little bit more medial, some have it a little bit more lateral. So I'm not a big fan of saying the arch has to be in one place, because if you look throughout even this room, brows are in very different places, and the arches are. As we age, what happens? We lose fat, we lose volume, the brow drops, and it starts to hang over the supraorbital rim. You get lateral hooding, and then you certainly get loss of the superior sulcus. In men, same thing. Brow placement is very varied, but the standard male brow should be at or above the rim. We don't want it below the rim. And again, it's usually more of a flatter brow without an arch. But again, some patients, some people have natural arches. You have to take that into consideration when doing the brow lift. The other thing that you start to notice as we age, and this is in both men and women, you start to get hypertonicity of the frontalis, and that's because everybody's walking around trying to hold their brow up because they feel that heaviness, that hooding, and so they start, they're talking to you, and everybody says, oh, it's just because I'm very expressive. You're trying to hold your brow up. So we want to be aware of that, talk to the patient about that, and deal with that also when we're doing our brow lift. Again, this is the, I was talking about there, so it's supposed to be the standard of where the brow goes. Everybody's going to be different. Need to talk to the patient about it specifically. The standard, they have this little formula and says that the arch, at least for a woman, should be right about the lateral limbus. Cook, who's one of our colleagues, came up with a paper and he said, oh no, it's not at the lateral limbus, it's actually at the lateral canthus. Like I said, everybody's brow is a little bit different. You have to talk to the patient, you have to evaluate the patient and come up with where you think their brow is going to look the best. Instead of just telling a patient, oh, you have brow ptosis, this is why, there is also an objective measure. McKinney published a paper that said brow ptosis is basically when the distance between the mid-pupillary line and the brow, the top of the brow, is less than 2.5 centimeters. This is also nice. I know a lot of us do cosmetics, but you can also get brow lifts and upper blepharoplasties covered by insurance, and certainly we do a lot of those also. When you're trying to get them approved, insurance is always like, well, I don't know, can you send pictures? So I usually try to put in as much objective information as possible, and then we usually can get them approved too. So the anatomy that we need to know, right? The superficial musculoaponeurotic system. I'm not going to take Ryan's thunder. This is basically a fibromuscular network that connects all the muscles of facial expression. It's basically the fascial highways, right? It's the structures that we're pulling on to change the shape and positioning of different areas of the face. The other important thing about knowing about these fascial networks is that they are your guide to protecting the facial anatomy, the facial nerve specifically, right? If you understand where the SMAS is and where the nerve is in association with the SMAS, you're going to be able to do these procedures safely without too much worry on doing damage. This is just a side view. The big thing is, again, it's all connected, right? So you have it going from the forehead back. This is the galeofrontalis occipital sling, and it extends literally from the brow all the way to the back of the head. It continues with the SMAS in the lower face, over the zygoma and actually sort of around the eye as the arcus marginalis. Remember the thing that you have to remember, the facial nerve as it crosses over the zygoma is right on the undersurface of the temporal parietal fascia. This is Dr. Bedrosian already talked about some of the anatomy. So you got the supraorbital rim, the muscles, frontalis, the orbicularis oculi, corrugator, procerus, and the depressors. Again, the only elevator is the frontalis. Everything else is depressing. Forehead sensory, again, important because you don't want your patient to come back and say, oh yeah, I look great, but I can't feel a thing. So important to remember, right, there's multiple nerves that we have to watch out for, supraorbital, supratrochlear, the zygomaticofacial, and really the zygomaticotemporal are the ones that are really at risk when we're doing the brow lifting. And then this is just, again, showing the facial nerve and where you have to be wary of it. Everybody talks about it as it's crossing over the zygoma. They say, if you stay away from that area, remember, even as you come up along the temporal area, the nerve is at risk. And there's always multiple branches. There's usually not just one specific branch. So just because you see one area, don't think that you're safe to
Kaş kaldıran
cauterize randomly in other areas. You have to realize that the nerve very often splits into multiple branches that supply different aspects of either the orbicularis or the frontalis muscle. One of the standards that we use is basically 2 centimeters. Literally, if you draw a line from the tragus to either the lateral brow or the lateral canthus, it's going to be right in that central area. I'll show you how I do my markings in a second. So, and then in forehead anatomy, as you're coming down on this lateral temporal incision, right, you're going to get underneath the superficial temporal fascia. You're going to get in that plane as you come down, and forgive me, this is backwards because this is the outside of the skin. As you're coming down in that plane, superficial temporal parietal fascia is up, the deep temporalis fascia is down. You're going to literally nick into the periosteum of the zygoma and lift that periosteum, and your nerve is going to be in the, right underneath the superficial parietal fascia, and it's going to be able to be elevated, and then you can literally come down onto the mid-face that way. And we'll talk about that in a second when I'm talking about mid-face lifting. So the approaches that we already talked about, there's coronal, there's pre-tracheal, post-tracheal, the mid-face, the direct, the blepharoplasty, which Dr. Pedrosian just explained, and then the endoscopic. In my practice, most of the cosmetic is really either endoscopic or the pre-tracheal. Don't do coronals. The mid-face, I mean, if we have a man with very sebaceous skin, we'll certainly do either a mid-face direct. I think it feminizes the brow a little bit much for most men. Some absolutely say, oh, no problem, and do it. But the majority of the brow lifts are going to be, for us, or I should say for myself, is pretracheal or endoscopic. So the indications for endoscopic lifting, brow ptosis, pseudotosis of the eyelid, glabellar rhytids, nasal root rhytids, or forehead rhytids, and frontalis muscle hypertrophy or hypertonicity. So it's not just the brow placement. If you have somebody who has deep furrowing, we can talk about brow lifting for that too. You don't always have to just fall back to your Botox. So the basic steps for endoscopic brow lifting. Excuse me. 6 basic steps: marking and anesthesia and incision, creation of an optical cavity centrally, your temporal dissection, the frontal dissection down low with identification of the neurovascular bundle with muscle release, your myotomies, and then your fixation. Pretty simple. The nice part about this is as you get a little bit more experienced in it, you can do the entire brow lift literally from start to finish somewhere between 50 minutes to an hour. I usually say 45 minutes to an hour for the entire thing. As mentioned before, we do it in the either in the JSC in the surgical center or in the hospital, just because we want to use sedation. We don't do sedation in our office. We'll do other procedures in the office, blepharoplasties, even facelifts, chin implants, things like that. This gets a little bit more invasive, so most patients aren't comfortable. Plus, we don't have the endoscopic equipment in the office. We have it in the hospital or surgical center. So they come in, they either get conscious sedation or full anesthesia. I leave it up to the patient on what they want. They can certainly do either. A lot of patients, amazing, just say, put me to sleep, wake me up when it's done, I'll be happy. So these are my markings for the endoscopic lift. I always mark out the 7th cranial nerve. We're always teaching residents, so it's always nice as a, to remind the residents of what structures they need to be wary of. It also reminds me, make sure that you keep this in the back of your mind. So I always mark off the course of the 7th cranial nerve. Next incision I do, and this one I always do when the patient's awake. Because you can see it's about a 4-centimeter incision in the temporal region, and they see this little line here. That line is the mark where the temporal line is. So what I do is I ask the patient before they go to sleep. I palpate and I say bite down, and I feel for the temporal line. Very easy to feel if you have somebody clenched down. If you feel on yourself, makes finding that a piece of cake. I forgot to do it in the beginning once or twice when I started doing these. I would forget and I'd be like, oh, and I'd try to feel it, and then you'd open up and you'd realize you were in completely, it was either all the way up here or all the way down here. So it's one of the most important steps, at least for me, is identifying that the temporal line. So that's my side markings. So that each one of those lateral incisions, each side. Centrally, I usually mark if there's some deep furrowing that I want to address with my myotomies. So here she had deep glabellar rhytids. So I'm going to address those. I mark either the superficial notch if I can feel it, or if I can feel it, sometimes you can even palpate the foramen. I always mark that out. The reason that's important is I usually will put my central incision somewhere either above it or lateral to it, almost never medial to it. Because what I found, and this is again as I've sort of changed the techniques a little bit, if you do your fixation too centrally, you can give a funny shape to the brow. It sort of brings up the medial aspect of the brow, which most people naturally don't have, and it looks a little awkward. Two is there's not a lot of elasticity centrally. It's more laterally. So as you raise everything up, that central area sort of picks up anyway. So you don't have to really worry about fixing very centrally. It's more sort of it laterally, right where it's marked. And usually I use about a centimeter lateral to the supraorbital notch to identify that. And that's all the markings. Just two central, two lateral. That's it. So then comes the endoscopic dissection. The important thing, which I learned the hard way, is when I first make my incisions in centrally, I take the knife, I go straight down to the, I think I have, I'm trying to think, yeah. So I take my knife and I go straight down through skin, subcutaneous tissue, and periosteum, and I open up so I can see the skull. Before I do anything, before I start elevating, I literally take my calipers, which I know, so I should say, everybody gets at least a centimeter elevation, okay? I used to think, oh, well, some people don't need that much, and, maybe I'll do, 8 millimeters, and the truth is, what I found out is, you want to get as much lift, for the endoscopics, you want to get as much lift as possible, because it does settle. And what you're lifting up here does not equate to what you're actually getting in brow elevation. So you want to get as much as possible. I never do under a centimeter, and most of mine are probably somewhere between 15 and 18 millimeters. So you can think, it's a nice sized distance. The nice part about the endoscopic brow lift and why it's so quick is I set my calipers, if I know I'm elevating 12 millimeters, I set my calipers to 12 millimeters. As soon as I make that first incision in these two central pockets, I take the caliper, I put the top prong into the crotch, the second prong comes wherever that distance is, I take my drill, I drill a hole, and that's it. I don't have to measure again because I know, I know that elevation is going to be appropriate. Then I just blindly take the periosteal elevators, and then we create our whole central pocket all the way around the entire forehead. And again, that's why it's so quick. None of this has to be done endoscopically. If you know you have a supraorbital notch, I put my finger about a centimeter above the notch, and I literally elevate everything up. Okay, so that's my entire forehead elevation. The thing that you do have to realize is sometimes there is a lateral supraorbital nerve or an accessory nerve. You try to preserve it. If you hit these smaller branches, it's not the end of the world. They usually get a little paresthesia, and it almost always comes back. I haven't had anybody come back and say that they didn't, they have a paresthesia from that. So the temporal dissection. So that whole central dissection, literally 5 minutes. The temporal dissection, you can see here, I'd make my incision. Right here's the temporal line. The nice part about this is you get right into the central pocket this way. Central pocket's already elevated. I find my temporalis muscle come through my superficial parietal the temporal parietal fascia. Lift the temporal parietal fascia till I find my muscle, and then I literally sweep right down the temporal line. And again, since this is a nice wide incision, you don't even need endoscopes for this. I do this usually with a lighted retractor, and I can follow this all the way down to the brow. Again, this whole portion may be 10 minutes. The thing about the endoscopic is you also have to elevate posteriorly, so all of this tissue back here gets elevated too, because as you move the brow back, you have to sort of spread the extra tissue around. And same thing after the central incisions. I usually go pretty far back, usually almost to occiput when I'm elevating in the subperiosteal layer. So as you come down in the temporal dissection, this is in the.
Şimdi burada diseksiyonu gösteriyor.
This is where the fat pad's lifted. You can see here's the temporalis muscle. Here's the temporal fat pad. In this one, you can see it's reversed. Here's the temporalis muscle, temporal fat pad. The difference is here's the nerve. If you're not comfortable getting close to the nerve, you go under the fat pad, lift the fat pad up. Nice part about this is from here you can go, if you just keep going straight, you're going to hit the zygoma. Right? Zygoma, though, is where the temporal parietal fascia is going to connect and then extend down into the lower face. So that's where you take your elevator and you literally incise right onto the zygoma, and you can actually elevate in a subperiosteal plane over the zygoma and into the midface. So joining the temporal and frontal cavities, again, since we're looking at it directly, it's not a problem. That's one of the easiest parts that people used to talk about all the time. The only other thing I wanted to share, I just want to go back to this picture. The only other thing I want to mention is, as you're coming through in this area, there's always little sentinel veins or sentinel vessels that are coming between the skin and the deeper tissues. If you nick through those, it's okay. The problem comes when you try to cauterize that. So I use this line. This is really where the line comes in handy, because sometimes you think I'm nowhere near the face and you have a little bleeding and you're like, oh, I'm going to grab the cautery. If you stop for a second, you use your instrument, you just push up, almost 9 times out of 10, you're literally right on this line, because as the nerve goes, you have these little vessels underneath it. So instead of cauterizing it, all you do is stop for a second, pack, taking out chunks of the muscle and thinking, oh, it's not going to reach and it's going to have a great result. It always grows back. But it does allow the healing. The patients love not having to get Botox for 8, 9, 10 months before the muscle starts. And again, the thing that you can notice is you really have to identify the neurovascular bundle before you start this, because again, the muscle bleeds pretty with that hole there. I didn't tell you why I put that hole there, but we've tried everything. I've tried suturing, I've tried the endotyne, I've tried basically different suturing techniques. I found that nothing works. It's funny, when I was in fellowship, my fellowship director did this. He's been practicing some 25, 30 years, and I was like, I'll never do that. I didn't like it. And the skin moves posteriorly. You just put a staple, and that staple holds the brow up. Depends on the bruising. Go back to work or go back to normal life. I'm not sure about the time, but I can quickly go through mid-face. Okay? I want to take a couple minutes. We'll go through this quickly. Mid-face lifting. So basically, concepts in mid-face lifting, it's myeloplication. Really, you want to just lift. So as we age, right, fat pads start to lose volume, they start to descend. They basically descend over fixed regions, right? These fixed regions are what we call our nasolabial folds, neurolabial folds. And basically, the fat pad drops, you get hollowing in here. Based on the concept, so this is all falls over fixed connections. Basically, the fat pad just descends. So how do we pick the fat pad up? Let me just say, I used to do more mid-face lifting. Now we've incorporated mid-face lifting into our facelifts. Ryan's going to talk about that a little bit, about how we specifically address that in the facelifts. So
şurası.
if somebody comes in, has no lower face complaints and really just has mid-face complaints, then that's when we'll do the endoscopic mid-face lift.
göz
Other
altında
than that,
çukurlaşmalar
we'll address it when we do
yapılabilir.
usually when we do a facelift, age. We talked about entry into the mid-face. This is the endoscopic approach. I do the
Burada
same approach as I
girişim
do
için
for my endoscopic.
kullandığı yer.
Just like I talked before, you can randomly
Burada
elevating.
operasyon sırasında görüyorsunuz.
Then once you elevate all of the cheek, how do you fix it? There's suturing techniques. We talked about the
Suture'le,
endotine,
yani,
which is considered a spike
dikişler
spike
tespit
lift.
edilir.
So,
Dün de anlattım, geçen gün anlattım.
oh, I forgot the name of
Aptos,
the what is it?
yardımıyla da
The coax,
tespit
thank you.
sağlanabilir.
As a direct, or
Bunlar
whether it's up
Aptos
in
cihazları.
in
Türkiye'de
the
maalesef yok şu
central
anda.
area. Patients feel these and are very bothered by it,
Açıkçası
even
çok
though
da
they
ihtiyaç
eventually absorb.
duyulduğunu düşünüyorum.
Feel it in their cheek, like they do
Burada
on the
onun
forehead.
tekniği anlatılıyor.
Again, evolution, and you get more comfortable with things. Now everything is done through
yani
the
şimdi
temporal incision. If
şöyle bir
need be, and you need
tartışmaya
to do
geçelim.
additional suturing, or you're not happy with it, you can always go in and.
Açıkçası yani tabii çok klasik bir orta yüz germe ve kaş kaldırma işlemi için size şöyle detaylıca bir sunumdan birazcık şey yapmak istedim, göstermek istedim. Görüyorsunuz yani tabii her elde her teknik farklılaşabiliyor. Endoskopik yüz germede de gördüğünüz gibi yani şakakta resmen 4-5 santimlik bir kesiyle yapıyor. Yani bizim hiç kullanmadığımız bir şey ve ihtiyacımız da yok bu arada. Yani bu anormal değil. Burada da sonuçlarını gösteriyor. Yine bir şey yapalım. Neyse. O yüzden esasında burada temel anlatmak istediği şey bence çok açık. Hastaya göre tercih ve tespit. Birçok hasta başka hastayı görerek geldiği için genellikle o hastada yapılan şeyleri kendine sanki uygunmuş gibi hissediyor ve onları yaptırmak istiyor. Bu tabii çok uygun bir tercih değil. Hastalara bunların iyice anlatılması gerekiyor. Endoskopik yöntemler sonsuz kuvvete de sahip değil. Belli bir gücü var. Herkes de belli oranlarda etkili olabiliyor. Yalnız en başta dediği gibi ben de aynı fikirdeyim. 7 sene civarında, 7-8 sene civarında etkilerini hissediyorsunuz. Tabii bence burada yapılan yaş da önemli. Daha erken yaşlarda yapılan hastalarda etkili daha uzun sürme ihtimali daha yüksek olabilir. Tekrarlanabilir bir ameliyat. Yani 7-8 sene sonra bir endoskopik lift yine yapılabilir. Tabii ki burada dokuların özellikle cilt altı dokulardaki elastikiyetin kaybı söz konusu değilse. Beni dinlediğiniz için teşekkür ederim. Sizlere iyi günler diliyorum. Saygılar.